Hello and welcome to this live AARP presentation, Disrupting Disparities in Dementia and Brain Health. This program is streaming live on both Facebook and YouTube, and it's also being recorded, so you'll be able to watch it again or share it with others later. In our brief hour together, we are going to cover a lot of great information. I invite you to use the comment section below to type your questions or comments, anything you may have as we go along. And then after we've heard from all of our presenters, we'll open up the conversation for Q&A and answer as many of your questions as we can. And now I'd like to turn things over to our AARP Michigan State Director, Paula Cunningham.
Thank you, Lisa, and kudos to you, and so much appreciation goes to you, Lisa, for your your tireless and efforts in terms of bringing this program together, but also your dedication toward looking at all things that are related to dementia and brain health. And I am excited about the expert panelists that you have brought together today, and I hope you will all stay tuned for the entire program so that we can hear your questions as well. AARP commissioned a report earlier this year talking about disrupting disparities, particularly pre and post COVID and what that means. And we've learned a lot in the last 2 years. And if nothing else, COVID-19 has really shone a spotlight on the disparities that exist in communities of color. Michigan is it is the fastest aging state in the nation. We will have more people over the age of 65 by 2025 than we have under the age of 17 by 2025, just 5 years from now. And what we know is that as people age, sometimes their health isn't as strong as it ought to be. But we also know that particularly with people of color, there are a lot of chronic diseases, or the term that we're hearing a lot, comorbidities attached to that, not because of negligence necessarily, but some of that has to do with the fact that they don't have the same access to healthcare. They don't have the same access to housing, to transportation, they have food deserts, and all of those elements impact their health and their mental health, their physical health and their mental health as well. We have learned in our reporting, in the Disrupt Disparities report over the last couple of years, and particularly this year, that African Americans are twice as likely to have dementia as older whites. Twice as likely. Hispanics are 1.5 times more likely to have dementia than non-Hispanics. And 82% of older adults believe it's important to have their thinking or memory checked. That's good, right? 82% think that's important. Check my memory, doctor. Check, make certain that I'm okay. However, only 16% receive regular cognitive assessments, according to the Alzheimer's. Similar research conducted by AARP found that relatively few adults, 36% to be exact, have been asked questions about their cognitive health during a checkup with their doctor. We've all got to speak up and ask questions and ask to be checked more frequently. A data point in an AARP poll in Michigan last month told a very poignant story. 17% of whites said they know someone who has died from COVID-19. That's tragic. 17% of whites know someone who died from COVID. However, that number among African Americans was 65% knew someone who had died from COVID. Folks, we can do a lot more to be advocates for our own health and our own wealth. One of the things that we want to make certain that people do also is age at home, in home community-based services. I'm sure you'll be hearing from the doctors that the familiarity of an environment is important as people age, particularly if there's some brain health or dementia going on, and they would prefer to stay in their own home as they age as well. They're more familiar with that. So we want to make certain that we become advocates of asking for more dollars to be spent for home and community-based services versus dollars being spent for nursing homes and other types of long-term support facilities. So let's make certain that we know what we can do, but also let's ask lots of good questions today from our expert panelists and make certain that we continue to advocate for ourselves and advocate for those who are 50 and older, and particularly those people who need our help and need our support when it comes to changing policies and changing laws. So let's get with it. as they would say. Our first panelist I'm going to introduce all of our panelists, but I'm going to ask you a question. We're going to spend an hour together today. At the end of that hour, what is it that you'd like for folks to be able to take away? So think about that as I introduce you. Our first person being introduced is a panelist, Dr. Edna Andrews, who is Alzheimer's Disease Research Center at the University of Michigan. Since 2008, Dr. Rose has assisted the University of Michigan Memory and Aging Program in connecting minority communities into Alzheimer's research by providing education on the risk factors, comorbidities, associated with dementia cognitive impairment. She has successfully enhanced the minority inclusion in research at the University of Michigan. That is huge because there are a lot of minorities who will not sign up for research or for these types of studies, but she has increased that number, and she's increased it from 3% to 48% in supported studies. Yay, congratulations. And she's done that through linkages with local churches, sororities, and social organizations. Dr. Rose received her Master's of Social Work undergraduate degree in psychology and nursing from Kennesaw University in Kennesaw, Georgia. And she also holds a certification for the American Nurses Association as a psychiatric mental health nurse. Dr. Rose serves as adjunct professor at Eastern Michigan University and Washtenaw Community College in the School of Nursing. We're so happy to have you with us today, Dr. Rose. So before we get into, what's the one thing you want people to take away from the presentation today?
The one thing that you need to take away is that we can actually decrease those disparities in Alzheimer's disease research in the population with research and through education. So stay tuned as we do an overview of Alzheimer's disease and give you the linkages that you can contact to contribute and to be a part of the Alzheimer's disease research. Thank you.
Excellent, excellent. So it's not just always looking for someone else to do it for us. We can also have an active role in this. Thank you, Dr. Rose. I look forward to hearing from you. Next, we're going to talk with Dr. Irving Vega. Dr. Vega has his PhD in Department of Translational Neuroscience, and Dr. Vega at Michigan State University. Dr. Vega obtained his undergraduate degree in biology from the University of Puerto Rico. He also continued his research training in the Department of Cell Biology and Neuroscience at the Graduate School of New Brunswick, Rutgers University, earning his PhD. Dr. Vega proceeded to a postdoctoral fellowship in the Neuroscience Department at Mayo Clinic in Jacksonville, where he developed his research, focusing on the identification of proteome changes associated with the accumulation of pathological tau proteins in neurodegenerative disorders such as Alzheimer's disease. I mean, we are so fortunate to have these expert panels with us. Dr. Vega, tell us, what's the one thing that you'd like for people to take away from the presentation today?
Thank you for that. Something that I invite people to think about is whether we are asking the right question about health disparities. We are actually focusing our intentions in developing new policies or even research questions. We are putting it in the right context, and we are focusing our effort to actually resolve the issues that lead to health disparities. It's not about race, it's not about ethnicity, it's not about the biology of the individuals. It's something else that affects us and put us in the disproportional risk of developing Alzheimer's disease and related dementias.
Thank you for that. And I really appreciate when I was reading your bio that you have really been very actively involved in increasing diversity in the field of neuroscience. So we need more neuroscientists out there. So thank you for that, Dr. Vega. We look forward to hearing from you. The next panelist that we'd like to introduce is Dr. Fay Sun, who is has PhD and also a MSW, Master's of Social Work. And Dr. Fay Sun was awarded as a Health and Aging Policy Fellow in 2017-2018. He is a professor at the School of Social Work at Michigan State University and received a doctoral degree from the University of Alabama in 2008. He was a Hartford Geriatric Social Work Scholar from 2009 to 2011. And Dr. Fay Sun also has been working with the Department of Mental Health and Substance Abuse of the World Health Organization on developing a global toolkit for dementia-friendly communities. I want to say that again, developing a community toolkit for dementia-friendly communities. We are anxious to hear more about that. He has published over 80 articles and books and chapters in the area of aging and health. His practical interests on psychosocial interventions for individuals with dementia and their family caregivers from ethnic minority backgrounds. Welcome. Glad to have you with us, Dr. Faison. What's the one takeaway that you have today?
Well, actually, I'm a little bit ambitious. I have two messages.
Okay.
The first one major takeaway is I want to convey that despite of the evidence to support the difference in prevalence and incidence rates of dementia across racial groups, most modifiable risk factors are similar, across racial and ethnic groups. For Asian American families, cultural values about aging, dementia, family, and the social system present challenges as well as limitations. So what I hope you will find useful or inspirational maybe from my talk are some evidence-supported strategies used by Asian American families to promote brain health. And the other message is, regardless what ethnic background we are from, if we open our mind and try to learn from other social or cultural groups, particularly those groups we have little knowledge before, it not only helps us stimulate our brain health, but also helps reduce disparities and misunderstanding between ethnic groups. That relates to policy. We can create dementia-friendly society.
I like the sound of that, creating a dementia-friendly society, and we all have a role to play in that. So thank you so much, Dr. Faison. Look forward to hearing your presentation today as well. And thank you to everyone who is listening to this broadcast. We very much appreciate you staying tuned in. So I'll turn it back over to Lisa Cooper to talk about disrupting disparities in dementia and brain health. Lisa.
Thank you, Paula, and thank you all for being with us today. I'm very excited about the information that we're talking about today and what we can get out of this, all of us together. What's going to happen next is we're going to hear from each of those three experts, one at a time, about 10 minutes each. And then we'll come back together for some Q&A. While the presentations are going on, again, please feel free to chat, put your comments in the box below the screen, any questions you might have, and then we'll come back together and go ahead and try to get all your questions answered. So let's start first with Dr. Edna Rose with the University of Michigan, Michigan Alzheimer's Disease Research Center.
Good morning, good morning. Now, we're going to really go over some of the Alzheimer's disease background to bring you up to where we next screen. First of all, this was developed by this disease by Augustus had a patient called D, and the doctor was Dr. Alzheimer's. This was in 1900 in Germany. And he had this patient, Augustine. He felt that she was not feeling herself. She felt like she was out of herself, not understanding what was going on as some changes in her memory. And so he continued to study Augustus D. And he found out at the end that there was some cognitive impairment. There was traces of plaque were left on the, and this began the study of Alzheimer's disease in 1901. The disease was not researched in the United States until 1970. You can change your screen again. And in 1970, it came to the United States, we began to study. So the question that's often asked when we go out to educate the different organizations, different ethnicities, is what is the difference between dementia and Alzheimer's? So we try and get them to see it in the form of an umbrella. There is an umbrella, and under the umbrella of dementia, there are lots of different types of Alzheimer's. And I mean, lots of different dementia. The one most known is Alzheimer's. So that's why often people, when there's memory impairment, straight to Alzheimer's disease, but that's not necessarily so. If you can see you have the frontal temporal dementia, the body dementia, you have vascular dementia. And this day, when we talk about the disparities in dementia among African Americans, we mostly look often at vascular dementia. And so today, as we talk about facing the disparities of dementia and brain health with the African American population, look at we call them comorbidities, those things that could be precursors to the disease. Next slide. When we look at the slide, we see the prevalence of you notice that the 50 to 70% of Alzheimer's is Alzheimer's disease, but oftentimes that dementia, the 10 to 15%, we find that in the African American population more so than in other populations. And oftentimes people are not diagnosed with, say, the Lewy body or the frontal temporal or the mixed phases until it gets to the Alzheimer's disease. Oftentimes we have family members that don't have a primary care in the African community, and so there's no one to refer them to a neurologist, the diagnosis of whatever the dementia might be before it gets Alzheimer's. By the time they go into the hospital or go to for care, it is already with the later stages of disease. Next film, next screen. This is just to show you what happens. The one on the left, that's a healthy neuron. The one on the right, that's a neuron that's actually been impaired. This is what takes place oftentimes in the African-American population. Oxygenation is not given to the brain. So just to kind of show you the difference between healthy neuron being able to transfer information and it has been impaired due to a lack of oxygen to the brain, sometimes with the, lots of times with the African-American population via a stroke. Next. And this, the healthy brain, at the University of Michigan, we have what we call the gift of life. And in the gift of life, this is where people that are in research donate their brains to research their death. And it's that gift that keeps on giving. So if you notice, the brain of a healthy person is at the top. You can see the difference in the sizes between a brain and an unhealthy brain. Next slide. Now, we talk about the prevalence, and worldwide, we have about 30 million cases. This number is expected to double every 20 years. By 30, we expect it to rise to about 65.7 million. But by 50, the prevalence is expected to quadruple, and the cost for caregivers and institutions will become astronomical. Next slide. Also, when we look at the cost to society, now these dates are from 2018, but in 2018, there was $277 billion that had to be used in for society to care for those with Alzheimer's disease. And $186 billion is the cost to Medicare and Medicaid, and then $60 billion is out-of-pocket costs that it takes for family members, say retiring early, leaving work early, or having these are the costs that are out of pocket. Now, when we talk about Alzheimer's disease, and we're not going to spend a lot of time here, this was just an overview to prepare you for our other speakers, but we talk about Alzheimer's disease taking place after the age of 65. It's gradual, and you began to see different parts of the brain that can be affected: language, orientation, familiar tasks, judgment, and personality behavior. The one good thing about research is that oftentimes people come into research early and that they can be tested in research. This will actually disrupt the disparities that we see in different communities. By coming into research, you can determine what parts of the brain are affected if you come in enough before you progress to a point that you cannot be tested. Next slide. Now, the reason I focus on vascular dementia and trying to disrupt those disparities in the African American population is because we are more prone to have what we call vascular dementia. It's most prevalent in the African American population, and this type of dementia is when there's a lack of oxygen that gets to the brain, such as people that have had multiple strokes. Now, the about research again is when you have these multiple strokes, times when you come in for research in our eyes of PET scans, they can see where damage has been done to different parts. But the vascular dementia in the African American population is caused by changes in diet or different type of diet. I think makeup plays a role, and often those precursors that we continue to educate about, the hypertension, the high cholesterol, the diabetes, the weight and the obesity and the lifestyle changes, these are associated with the stroke. And so we have to get to our African American population to decrease disparities by educating on precursors and how to prevent and how to manage some of the diseases that are. Next slide. Now, when we talk about disparities, Africans are more likely, and Paula brought some of this out in her introduction, but the African Americans are more likely to have conditions like hypertension and diabetes. Teams at AI 2017 presented evidence that poverty, disadvantage, stressful life events are associated with cognitive problems in middle age and late dementia African Americans. Africans who grow up in harsh environments and endure stressful experiences are much more likely to develop Alzheimer's disease. The research also suggests that genetics are not a contribution, but this is one of the reasons. If we want to disrupt the disparities in the African American population, we must become a part of it so that we can get the information about how we are different from other populations and disrupt the disparities by ways to slow the process down and ways of prevention. Next slide. The African American disparities. African Americans is likely to have diabetes as non-Hispanic whites. African Americans are 40% more likely than whites to have high blood pressure and 10% less likely to have it under control. Africans, men and women, are 30% more likely to die from heart disease than non-Hispanic whites. And African adults are 1.0 times as likely to have than non-Hispanic whites. This is why prevention is going to decrease the disparities more than anything else, and the education of the African American community, as well as participation of African American research. Next slide. Among people aged 55 or more, African Americans are 4 times more likely than whites to have cognitive impairment. And among people 85 and older, African Americans are about 2 times more likely than white cognitive impairment. About 20% of African Americans aged 71 and older have Alzheimer's disease or related dementia. You can begin to see how the African American population has the diagnosis is essentially higher than other ethnicities. Next slide. Why African Americans are needed for research. And I keep going back to research because the one way we know that increase the disparities is if we're in research. To study the impact of the metabolic syndrome and the multiple comorbidities, the high blood pressure, the cholesterol, the diabetes, why these things cause us to progress towards cognitive impairment more so than others. We're needed in research to determine why there is a disproportionately higher incidence of Alzheimer's disease in the African American population. And we need to continue to study the specific gene, a precursor in the African American population. And now some studies suggest that there are specific genes, but additional studies must be done and research participants will be needed. In order for out, we must be a part of research because we add to the body of knowledge and they're able to generalize the findings and increase cultural sensitivity. We can also identify the unique responses to treatment by different ethnicities, but we all must become a part in order for that to take place. Next. We'll refer the question until later on, and any questions that you make sure that you just dot that so we can answer those questions the 3 of us have presented. Thank you for your time this evening.
Thank you very much, Dr. Rose. And I see we are getting some great questions and comments in the Q&A in the comment section. So keep that coming. We are going to come back and do Q&A in just a moment. Also, I see in our comment section that Sarah Lenz-Locke, who is AARP's Senior Vice President for Policy and the chair of the Global Council on Brain Health, has joined us and is giving us some links in the comments as well. So that is fantastic. Next, I'm going to move to Dr. Irving Vega for him to give us his presentation.
Thank you, Lisa, and thank you, Dr. Rose, for that great introduction about Alzheimer's disease, which give me the time to direct the discussion in another area. I took at heart the title of this webinar, Disrupting Disparities. I want to challenge your concept of the concepts that you have about health disparities and how disproportional it affects people in the Black community and in the Latino community and other communities like Dr. Fain will describe. Before I start, I don't have any conflict in the next slide, conflict of interest to declare. I do participate in different organizations and the opinions are my own and not the views of my employer or the organizations that I'm associated with. As I started, in the next slide, I put the same question. Are we asking the right questions about health disparities? Health disparities is the disproportional risk that people have to develop specific diseases. It doesn't have to do anything with the ethnicity of the individuals. It doesn't have to do anything with the color of the skin or nationality. It does we find the root of it actually in the segregation in our social disparities, in how we treat different groups and the access to healthcare that different groups have. And we have to start thinking about what are the biases and what is the racism that is leading to those disparities in our society, and how those biases and racism actually gets into the experimental design when we are actually conducting research in academia. I think all of you have seen this picture before that illustrates equity. And I want to use this illustration to actually deconstruct it, disrupt it, and actually find within it the biases that we have into these questions of health disparities associated to Alzheimer's disease and other dementias. If you look at this slide, at this illustration, you see three individuals. And we define the process that was done for them to watch that baseball game as equity. But however, when we look at this guy and what was done to reach equity, we might have to think that we actually developing a new barrier for this individual. This construction or this policy, let's say, use the term policy here, is actually twice as high as this individual. So when we're building policies to reach equity, or we poorly write policies, we might be developing new barriers to individuals, and those barriers actually can affect how those individuals have the access. And sometimes we ask, we did all this, we have a diversity, equity, inclusion office, we have all these resources for people in the Black community, in the Latino community, and other communities, and they still don't come. Well, think about it. Maybe you're actually making it really hard for this guy to be able to get there. I don't know how this guy got there. Someone probably have to also help him to step all the way up. But at the same time, we think that the problem is the fence in front of it. And if we focus our attention to try to resolve that fence in front of it, we are actually probably only dealing with the symptoms of the disease, but not the cause of the disease. We are probably looking at the consequences of other actions rather than those actions that promote, in this case, health disparities. What we should be asking is why these individuals are not sitting at the stands, at the bleachers, where the other people are. Why these individuals have the difficulty of getting access to what most people have. Why is that the case? I think that's where the root of the problem is of health disparities. We are not asking the right questions. We are looking at the symptoms, and we're not looking at the actual problem, that is the segregation and the social disparities that differentially affects individuals, putting them at higher risk of developing Alzheimer's disease and other dementias. And you can see in the studies of prevalence, these are studies among Black Americans, Latinos, and non-Latinos, non-Latino whites. And what you can see in these different studies listed here is actually the variability in the prevalence. When you do the average, there is more among African Americans and Latinos, especially Caribbean, what is called Caribbean Hispanics. However, you can see the variability of it. And the variability actually tells us something about the experimental design. It tells us something about how we approach these communities. And it's most of the time based on the zip code, which is actually lead, and it's the first introduction of a bias, because we know how segregated these populations are. And we don't take a sample that really represent all the Latinos, all the Blacks, and all the whites. what we know in terms of the Latinos is that people, U.S.-born Latinos are different than foreign-born Latinos. In the next slide, I can show you a recent study that we published in the Journal of Alzheimer's Disease, where we compare non-Latinos white, that is the NLW in the graph, the US-born Latinos, which is the USBL in the graph, and then we segregated 3 different groups of foreign-born Latinos, those that moved to the United States when they were younger than 18 years of age, those that migrated to the United States when they were between 18 and 34 years of age, and those that were 35 years of age or older when they moved to the United States. When you look at the gray square, that is the cognitive function at baseline, adjusted by age and sex, you can see that regardless of the group, either US-born Latinos or foreigner-born Latinos, they actually have a poorer cognitive performance than non-Latinos whites. So the cognitive function is lower than non-Latinos whites. However, when you add to the adjustment, to the correction, years of education, now you can start seeing differences. You can see that the US-born Latinos is still, their cognitive function is lower at baseline than the non-Latinos white. However, the foreign-born Latinos, regardless of the age that they move to United States, you can see that the cognitive function, there's no significant difference with the non-Latinos whites. That again, that suggests that is something of those Latinos that are born in United States, not the ones that migrated, that are in disadvantage and are developing less of having problem with cognitive function than the one that migrated. And when you look at the different domains in that cognitive screen, memory and serial 7, which is actually working memory and attention, you can see that the younger, if you migrate, Latinos that migrate before the 34 years of age actually are much better than Latinos that are born here in the United States. And then if we then look at the probability of being with normal condition versus cognitive impairment with no dementia and those with dementia, you can see the same thing. You see higher probability of developing cognitive impairment and dementia among US-born Latinos compared to whites versus Latinos that migrated at different age. And actually, you can see the normal condition, the probability is higher among those that are born outside of the United States, regardless of the age when they migrated to the United States in comparison to those Latinos that were born here in the United States. So we know that is social determinants of health, the ones that promote these differences. And in the next slide, you can see that are those, next slide, you can see the 3 main factors of social determinant of health. Contextual factors that Dr. Rose mentioned in terms of the stress that our communities live. That social political environment that in the Latinos community are affecting the way they move and the way they actually communicate and participate within the community. How that contextual factors affects the biology of the brain and affects access to education, which actually less education is associated with worse health outcomes. And then those worse health outcomes actually affects also education. And it's like a vicious cycle of affecting the individual. Dr. Rose also mentioned in the next, like I'm going to show in the next slide, that this social determinant of health affects every individual. And Dr. Fain will also talk about that, where regardless of the social determinant of health affects all ethnic groups. In this graph, I can show you less years of people that have 12 years or less of education, people in poverty, or those that were that have rural as a residence. The cognitive impairment in those is higher, regardless whether they are Black Americans, Latinos, or whites. There's more cognitive impairment. So the social determinant of health affects everyone. So when we look at what the social determinants of health do, is actually to promoting the risk of chronic diseases that has been associated with Alzheimer's disease. You see that in that populations, you have an increase in diabetes, obesity, hypertension, hyperlipidemia. All those chronic diseases led to affects neuronal function and affect also the vasculature in the brain, leading to Alzheimer's disease, higher risk to Alzheimer's disease and vascular dementia. And we know what we can do, but we are not asking the right question. We are not addressing the root of the problem. We are trying to study the symptoms. And now, while we are doing that, we have a new one. We have COVID-19. Next. We have COVID-19 as one of the risk factors that we have to add, because COVID-19 is known to have neurological manifestations that affects not only the vasculature in the brain, but also affects different areas in the brain. And that is being studied right now. So in the future, now we have to add as a risk factor COVID-19 as one that will affect the probability, and we know that Latinos and Black Americans are more affected. Here in Michigan, we are actually can see a division in the map where in the east, there are more Black Americans affected by COVID-19, and in the west, we have the Latinos more affected by COVID-19. That putting, again, due to disproportional exposure to this virus, putting these communities more at risk of developing Alzheimer's disease and related dementias in the future. We know in the next slide recently was actually a commentary, and we have known this for the past 6, 7, 9 years, that if we deal with the social determinant of health and we intervene and ask the right questions, we can actually reduce the cases of dementia by half. But we are not doing it. We are actually not addressing the root of the problem, is the biases, the racism in our policies that actually go into our research questions as well. So thank you for the opportunity, and I look forward to talk to you and answer questions.
Thank you, Dr. Vega. Wonderful information, amazing. We are getting a lot of questions in the comment section, and that's fantastic. I hope people will continue to put your questions in the comment section. Next, I'm going to call on Dr. Fei's son to provide us with information. We'll pull his slides up here too.
Well, first, I'd like to thank AARP for the invitation. It really feels different when you receive an invitation from AARP to give a talk than to join their club. I'm very excited about the opportunity to talk about the impact of dementia on Asian American families. And you may be curious, there may be some questions in your mind. How frequently do Asian Americans get dementia? Is it lower than non-Asian groups? And how, if so, what are some possible reasons? Is it because, Black do not crack, Asians do not reason? Or what we can learn from the Asian groups in terms of promoting brain health? So I suppose there are two groups online today. One group, you may have known someone who is Asian, right? And the other group, you probably never met someone who is Asian, but you're going to meet one, which is me. It's not surprising in Michigan you have never met someone who is Asian American, because statewide we only have 3.5% of the population of the Asian Americans. And the 6th largest group, as you can see on this slide, is Asian Indians, Chinese, and Koreans. Next slide. However, Asians is like Latinos. It's not a homogeneous group. there are 22 Asian background groups in Michigan. And you can see on the slide, about 7 groups, they're less than 1% of the total Asians. So the Chinese, Indian, and Korean accounts more than 50% of the total Asian. But still, there are many other Asian groups that account only for a small proportion. Next. But the next slide. But those small groups of Asian Americans, they're growing at a much faster speed than those major Asian groups. Like Nepalese, from 2011 to 2019, they grow about 500%. Malaysia as well. But remember, for Nepalese, it took them 90 years from a category of others in the census data to a specific ethnic group in the census data. So the first Nepalese in the US is started in 1880s, but it was not until 1974 Nepalese become a separate ethnic group. So for Asian Americans related to all those social equity or disjustice issues, is to get them to be seen, to get them visible, is one of the root cause for those disparities faced by those small Asian groups. So next slide. So both Dr. Ivan and Dr. Rose can talk about, there are pretty solid evidence to support there is race ethnicity differences between Blacks and Caucasians, between Latinos and Caucasians. Unfortunately, we have no hard evidence or no hard data to say Asian Americans have either high prevalence or low prevalence of dementia than the non-Latino whites. The only study we can find is a small study that found Asian Americans, for some Asian Americans, they do have low rates of dementia, do have low rates of incident rates of dementia than Caucasians, with Filipino being the highest, followed by Asian Indians and the Chinese. So the disparity facing Asian Americans is first is to get themselves to involved in the researchers' attention or probably policymakers' attention to get more studies to be conducted on Asian Americans so that we can have hard evidence to look at those data. Next. So what I'm going to talk about next is I'm going to highlight some risk factors along 3 domains: physical, psychological, and social, through a cultural lens, and to highlight those risk factors and some culturally sensitive plus evidence-supported practices by Asian Americans to promote brain health. Next. Similar to African Americans and Latino Americans, cardiovascular disease or vascular dementia is prevalent in Asian Americans as well. So that probably relates to hypertension, high cholesterol, and diabetes in this group. Possibly nutrition contributes to that fact. Pain, I want to highlight pain. For Asian Americans, for some groups, they have a high tolerance of pain. For example, like Filipinos and Asian Indians, they do not like taking pain medications. So that may result in a poor management of pain among those groups. Also, like poor quality of sleep, this is also a risk factor for brain health. For some Asians, they have preference for daytime sleep, a nap. But for others, like Japan, they do have like sleep deprivation is quite common. So some commonly cultural practice like play Tai Chi in Chinese Americans or play Taekwondo in Korean Americans has some evidence-based support tend to be good for your brain health. Like healthy eating, like the traditional Japanese food, like wasoku, with rice, with some seasoned dishes and a small piece of fish tend to have some research evidence to show that they're helpful to your brain health. Next slide. From the psychological perspective, I want to also highlight 2 things. One is the trauma for some refugee groups from Southeast Asian groups. So those groups that are refugees, either from war, particularly for recent refugee groups like Bhutanese and Burmese. So the trauma and isolation among those elders from those groups are prevalent. And combine the second component, which is the lack of mental health literacy. They are not being able to seeking help for their mental health issues, not just for dementia, but also for depression, anxiety, or trauma. So all those combined contributing to a high risk factor for depression and as well as for dementia. So one strategy I recommend is to promote intergenerational and family support. As that's the their cultural strengths, it relies on the family support and community support. For example, many holidays in those Asian cultures are not national holidays. Like actually today, for some Asians, this is Mid-Autumn Day. It's like Chinese or Koreans or Japanese Thanksgiving Day today, it's Thanksgiving holiday. But it's not a national observed holiday in America. So I encourage families who has a family from Asian backgrounds. So you need to spend some time on those non-national holidays, but it's your cultural holidays with your old relatives. Some other strategies, the peer support in the housing department, particularly when you live in a senior housing facility with other the same ethnic groups. Next slide. Social aspects. The risk factors for social aspects, we often heard about like social isolation, loneliness. Those are risk factors for your brain health, also for your cognition. For Asian Americans, most old Asian Americans, they were not born in the United States. So the language presents a barrier. And lack of familiarities or lack of the trust of the formal service system, like healthcare or social system, present another barrier for this group. Some recommended strategies we can see that often practiced in the Asian groups, like playing mahjong or play other board cards games that is suited for this cultural group, tends to be not only socially helping these old adults to overcome social isolation, but also helps to stimulate the brain cells. I'm not going to elaborate it for the time's sake. Next slide. So one last thing I want to emphasize is across racial groups or across cultural and race ethnicity groups, learning a new thing or making a new friend is always going to stimulate like a dopamine in your brain. It's good for your brain health. For Asian Americans, if you mention, I love particularly some ethnic food. Like for Chinese, you can say, I love dumplings. Well, it may bring you closer to your Chinese neighbor, and it may actually get you some dumplings in the end. But what I encourage you is to try to understand a cultural group that you have little knowledge before. And one message for the Asian elders, I don't know how many of them are joining this online session today. I guess it will be very few. So I will encourage you guys to attend those health workshops, to talk to your service providers and educate policymakers. Get yourself to be seen, get yourself visible, join research efforts so that we can generate more research or evidence on this group. Remember, you met one Asian American today, which is me, but I am like just people talking about person with dementia. You just met one Asian person. It just represents one person. That concludes my presentation. Welcome any questions.
Thank you, Dr. Sun. And how do you say that again? The I love dumplings?
I love 我爱饺子. It's really hard, but learning a new language is helpful to your brain. 我爱饺子.
Because, well, I chow.
You're very good, very good. You pick up very good.
So thank you so much, all three of you. Wonderful, amazing, eye-opening information. And I hope that we will continue having discussion about this way past this hour. We do have a number of questions. I'm going to start going through. First off, I see a question for Dr. Rose from Kathleen Ann on Facebook. And she asked, what research projects are out there for participation and how early can a person enroll in a research project?
There's multiple research projects out there right now. Because of COVID, we have been put on hold as far as our enrollment, seeing in person. All of the research is available. Usually we try and start at about 55 to 65 years because we're not going to see the changes until about 65 unless there's a very strong family history of all disease. So we usually try and wait until about 60 or 65 to bring people into research. And that research, we have longitudinal studies. We have, I think there's about 14, 15 different studies there. And so we have the inclusion and exclusion criteria, and that would be a determinant as to which one you would go into, which one would be most favorable for you.
Great. Is there a website or a place that people should go to watch for the availability of research projects?
And what we can do is if I can get you to put our website up, Lisa, on the chat line for them, just go to our website, and when you visit our website, you'll see the different people on the website. But I'll tell you how to become involved in research. So it's at the University of Michigan Alzheimer's Disease Research Center. It's our website that you would go to. Okay, so I'll try and get that to Lisa while we ask questions.
Okay, and then actually that brings me up to, or reminds me, I wanted to mention that we have this research guide or a resource guide that's available for Michigan that AARP Michigan has put together. You can find this resource guide that does include information about learning about research opportunities, also connections to all sorts of different groups that are specific types of dementia specific, information about resources for family caregivers, and just information for everyone at the beginning of your journey. One of the things that I know that we have heard at AARP is that there's a lot of information out there about dementia, but there's so much it can be overwhelming. You just don't know where to start. And so that's why we created this resource guide as a starting point to give you some basic information and help you get linked to more information and services, resources here in Michigan. The website for you to go on and get that and other information we'll share on that website as well is aarp.org/MI-dementia. And you can see it there. You can download it. Yeah, we'll put that there. And then I see we do have a question from Mary Ellen who asked about getting that guide. So we talked about getting it online. If you are interested and you put in comments that you would like us to send you a printed copy, maybe a couple of printed copies, then we will also, we can mail you copies of this guide as well. So we'll connect afterwards. We don't want you to put your address in the comments, but let us know and we'll connect and get your address. A couple more questions. I'm going to go quickly. A question from Dave on YouTube. He's asking, for all the panel experts, what kinds of public policies would you like to see implemented to help with dementia disparities on state and local levels?
I think one for the African American population would have to be with the insurance carriers being able to have ability to a primary, not only their primary care physician, but neurologist to make that diagnosis. Sometimes in the African American population, finding a primary care physician, and without the insurance, that route is very difficult. Making that route is going to be necessary to get that diagnosis rather than just treatments with medication.
Yeah, healthcare disparities is one aspect, but at the same time, an important one. And at the same time, we should be investing more on those factors that we know are good for our brain. Education, quality of education, not a matter of having a school that is with lack of resources. We know what a quality of education is, how to reduce stress in our communities, and as a society, how we can promote mental health within our communities so that we can reduce that stress that actually affects a lot of, and is the root of a lot of chronic diseases within our communities.
So to add to Ivan's point is, I would recommend a coordinated a system that from prevention to screening to treatment, particularly targeting to the ethnic minority groups, from community outreach and to early screening and to linkage them to early diagnosis and treatment. If a policy can support that in place, that would be good.
Thank you. Great points. Question for Dr. Vega from Sarah. Can you tell us more about the research questions that are inherently biased, and what do we need to do to change those?
Yes, that's a good question, and thank you, because it gives me the opportunity to expand. As researchers, sometimes we look at the symptoms of the problem and not actually the cause of the problem. And for example, I can tell you there are a lot of studies that go after the color of the skin, the race of the individual to try to explain the pathological process without taking in consideration the context where those individuals were that actually have the impact in the biology. Not the biology doesn't have an impact in the environment. The environment has the impact on the biology. So if we actually start asking the right question, let me give you an actual recent example. They were looking at Black Americans versus non-Latinos white, the biomarkers of Alzheimer's disease in the cerebrospinal fluid. And they found that there were some differences in Black American versus non-Latinos white. And they found that the volume of the hippocampus was less in the Black Americans than in the non-Latinos white. The conclusion of that study was that race-dependent factors contribute to the presentation of the disease. Very influential group of researchers in the Alzheimer's field. Completely biased conclusion, no biological principle at all for that conclusion. And that actually is, even right now in a recent study last month, actually, no, we are still in September. No, it's October. It's October. This past month, early September, they look at the expression of a protein that modified the receptor that SARS-CoV-2 used to enter into the cell. And they look at Black Americans again. And they say that because there's more expression of that protein, that's why Black Americans are more infected by SARS-CoV-2 than other groups. There are multiple papers already published that the zip code is what determines how many people, the infectivity of the individuals, the increased infectivity on the individual, and also that they work in a specific line of work that are more exposed to get infected. Nothing to do with the biology. Those are just two examples of how biases get into the experimental design and how we perpetuate the discrimination rather than asking the right question to solve the problem that differentially expose underrepresented groups and underserved groups in these diseases.
Great, thank you. Wow. Again, I'm going to go through some others. I'm going to combine some questions here. We've got quite a few people who are asking about things like nutrition prevention. So Saray on Facebook is asking, prevention is key is what we're hearing. So what are your thoughts for the group on getting this message out to the public? How do we get that message out? Prevention, good diet, all those things that you talked about.
So you've done great with this presentation, and we need more presentations of this kind in order to get it out. The University of Michigan, we started a satellite clinic in the Detroit area where we reached out to the different churches, the sororities, the fraternities, and that's one way to get it out, especially for the African American population. They gave us a stand. But in order to get the educational components out, that's the only way that we're going to get people into prevention. And even, like I said, even to educate, you've got to get those groups together. And in the African American population, between the fraternities, the sororities, churches, going out into the communities where we are located, we must leave where we are to into the areas where the disparities are, bring that information to them, and then create ways for them to become a part of or to participate, whether it be in transportation or relocating ourselves so that we are more accessible. But that's going to be the key to the prevention, is the educational component, like Dr. Faison has spoken of.
Yeah, I would like to follow that. Is also, thank you, Dr. Rose, following the dementia-friendly activities that we need to do, like Dr. Fay was saying. I think that we need to create a society where everyone takes the responsibility to move into a more healthy communities, into a more, and things that we know promote brain health. The supermarkets, the convenience stores, everyone can highlight what is important and what you can eat, for example, what you can eat that is good for your brain. We do it for organic food. We are doing it for, we can actually contribute and involve all the aspects in the economy to contribute in the menu in the restaurants. What is better? You know, we list the calories. Why we don't list what is good for your brain? Let's start doing that.
Just a quick comment to add to Arvin's point is we can expand our thinking of media, or not just as social media or new technology, like, you know, home delivered meal persons. Those persons can be a good like outreach to those people educating about nutrition, brain health, and other medias that are particularly compatible to the, you know, ethnic minority groups. You know, some Asian groups, they may still using radio. You know, those traditional technologies still may be prevalent in certain ethnic groups. So AARP does a good job, and AARP as a major like a club, they may collaborate with other ethnic minority groups club to expand their membership or expand their outreach to those non-Latino, non-Caucasian groups.
Thank you. Great information. And, you know, to continue this conversation, because we have had so many points raised, I think a lot of eyes opened, and there's so much work to be done. This presentation that we have today is going to stay up on our Facebook page here. And the comments, I know we didn't get to all the questions, but we can continue the conversation in the comments. Similarly, this will be up on our YouTube page. And we invite everybody who participated today to share this in your networks. And we will also put up information that we talked about on the aarp.org/MI-dementia resource page. But again, this is so important. I hope that we can continue this conversation. I'm so very grateful for our presentation, our presenters, and the work that you are doing day in and day out. And we want to do everything we can to help amplify that and really get some progress in this direction. So thank you all for your participation today. Thank you all at home for being with us. And again, I hope we continue this conversation in the comments and in real life.
Thank you.